questions for you, and you'll need to send those to Terry along with your license number so that we can make sure you get the CE credits. But the questions will be at the very end. We're not allowed, the state has told us we're not allowed to give you questions and answers, so you're going to have to be on your toes a little bit to be able to answer the questions at the end. So I'm reminded we were initially going to have Doug do the masters, the emceeing at the front end, but I'm doing the emceeing right now, and then Doug will kind of wrap us up at the end, and jumping in as we go, and we want you all to jump in. But it reminded me as I was thinking about this, it reminded me of the time as a young father. I used to tell my kids stories every night, go in their bedroom, lay on the floor and tell them a story. They'd look forward to that. My last son, my number 5 son, the last child of 6, I'd go in there and lay on the floor. And one night I went in there and he was over on the far away part of the bed. And he said, "Dad, I want you to sleep right here. I want you to lay right here." And he was very insistent on this. Now, this kid was a monster expert. Every monster he knew. But anyway, I finally got a little exasperated with him because he wanted me to be in this one particular spot. And I said, "Mark, how come you want me right there?" And he said, "Well, Dad, the monster in the closet, they come out and they eat the fat ones first." So anyway, that was the first time I had somebody that close to me tell me that I was the fat one. But anyway, this morning we're going to be talking about Medicare Market Dynamics. It's going to be kind of an AEP review, an OEP review, beneficiary choices, opportunities, and proposed CMS changes. Anyway, it's the data that we're working with was really hard to decipher, and it kind of made me think of a person who wears belts and suspenders at the same time. What does that tell you? That person doesn't trust his pants. So we're kind of in the same boat on this. Is the data, we did our best to try to get the data in a way that it was presentable and you could understand it, and hopefully you can get some information that you can use as you do business. So let's get going here. We're going to review the annual enrollment results, but we don't have the kind of data that we've had in the past. Our source for the data that we've used over the years, the website quit putting out the data that was easy to see and understand, to see what was going on. But we are going to review northern Utah, the counties in northern Utah, as well as southern Utah, particularly Iron and Washington County. So with that, Doug, go ahead.
Yeah, so as Bob mentioned, in the past, we've always been able to compare the performance plan by plan. And it's still possible to do that. We started doing that ourselves when we found out that our 2 primary sources are no longer working. They're not working because my understanding is that Integrity now owns both those sources, and they're still trying to get their ducks in a row. And so we were able to take some of the data from the CSG actuarial website, but they chose not to break it down plan by plan. So we were not able to come up with data that we found trustworthy. So what we're going to do is just go through the counties real quickly and just show you a little bit about the penetration of the various Medicare Advantage plans. And then we're going to give you our best guess by carrier. So it's guess, it's not the actual numbers. because, like I say, as we looked at the numbers that were being given to us, they became so untrustworthy that we just didn't want to give you the numbers. So we came up with an alternative. What I'd like you to notice here is, and we may very well be able to come up with good numbers at some point down the road if these people do this. You could actually do it yourself if you knew how the Medicare or the CMS HPMS data defined its columns. We just didn't have time to pursue that ourselves. So what I'd like you to notice here on Cache County is it's got 3 months. Each of these counties that we're going to look at briefly have 3 months of data. November 2022 at the bottom, December 2022, and then January of 23. You'll notice that there is a measurable increase in the penetration or the market share of the Medicare Advantage plans. These are all about Medicare Advantage plans. And you'll see that, though sometimes you'll see a dip in December. We're not quite sure why that's happening, but you'll see a very small dip that's almost always, if memory serves me, it's always compensated by an increase in January. So notice the trend here in Cache County from November, we're increasing by more than a percentage point in Cache County. Bob, next slide. Weber County, notice the same thing here. It is an upward trend. So we increase almost 2 percentage points in penetration in these 3 months. Next slide. Salt Lake County, again, it is an upward trend in market penetration. Medicare Advantage is taking over. I think that most agents and most seniors are seeing that, especially in the extra benefits, the dental and the hearing aids and everything, that it is outcompeting the Medicare supplements, though the supplements are trying to get creative and get back into the game. Next slide. Utah County, there's just a small dip here, and it's so small that it could actually be a measuring error in December of 2022. Or maybe some people decided to move over to a group plan or something like that. But overall, the trend is up, and it's more than a percentage point from November to January. Next slide. Davis County, it is almost 2 percentage points up between November and January, so they're embracing Medicare Advantage there as well. Next slide. Iron County, again, you see the same thing here, more than 2 full percentage point rise with a small dip in December that is hard to account for, and it's so small that it could be a measuring error. And
one of the things, let me jump in real quick. One of the things I think is interesting here is the previous counties that we looked at were over 50% penetration, and here we're looking at Iron County, and you'll see on Washington County too, we're looking at 40%. And I was trying to come up within my own mind as to why the numbers would be so low. And as Doug and I talked about this, we came up with the idea that, maybe med supplement is much higher because they've been around longer.
It was quite a while before the Medicare Advantage insurance companies decided that it was. Hey, Paul, could you mute your mic? Paul Bonnet, could you mute your mic?
Oh, dear.
That's Bob. No, I've not seen anybody today. Go ahead.
Thank you. So the carriers in Washington and Iron counties compared to the Wasatch Front were much later to the game. So, in my mind, it's the lower penetration is due simply to the fact that the carriers weren't offering the same value down there until quite recently. And they've only gotten they've only gotten competitive down there. And so we just haven't had the time to get up to the same penetration numbers as up in the.
I had an additional thought, and that is probably the biggest employer in Iron County is the Southern Utah University. And I know they have a relationship with one of our Stonehill agents there. And every time someone hits 65 or retires, the university has them talk to one of our Stonehill agents. And again, in the past, it's been Med Supplement has been the name of the game down there.
Okay. Again, so now we're down in Washington County, and again, we are seeing an increase of just a little less than 2 points in these 2 or 3 months that we've got going.
I think one of the other contributing factors is a lot of people in rural Utah, which Iron and Washington is starting to get to be an urban county. But I think there's a higher percentage of people working past 65 and they're still in a employee plan.
Okay. Bob, next slide and over to you.
All right, great. This is from the numbers that we were able to work with a little bit. We came up with, this is the market share by carrier across the state. And as we've always thought and knew that UnitedHealthcare was the gorilla in the marketplace, but their market share is eroding. Even though they still have an increase, I think overall their market share is eroding, but they're still number one. Then you're looking at, from what I could decipher, it looked like Humana was number one, and I think that's a reflection of Humana really coming to the table, so to speak, with great benefits the last couple of years. The next one that I deciphered being a number 3 position was Select Health. And I think that has a lot to do with their local name recognition with Intermountain Healthcare. I think there's a direct correlation there between the two. I think the 5-star rating Select Health has is just starting to have an impact in the marketplace. I think it certainly did during AEP. Next one is Aetna. Aetna, I think, was pretty, talking to the Aetna people, it sounds like Aetna was pretty level, but their market share has been based on previous years. It's interesting to me, I was with Regents the other day. Regents told me that during AEP, they were pretty static, pretty level, but during this OEP, they're seeing a decent increase during OEP. They told me that as they have talked to consumers, they get the feeling that consumers are telling them, well, I want to try something else, but I'm reluctant to stay on the road, and I found out I could make a change, and so the Blue Cross brand has come to the forefront. Cigna is there, as well as Molina, and the one that I was surprised by, the numbers I could decipher, was the University of Utah plan not having as big as impact as I thought they would. Anyone have any ideas about that? Any ideas why University of Utah wouldn't be as popular? I think, one of the things that I think really helped Select Health was them, bringing University of Utah online with their plan. But why the University of Utah is down there, tail of the dog, so to speak, I don't quite understand why that would be. Any ideas?
I do have some speculation, Bob. So, I think that it's a quality plan and quality people are there. But I think 2 things are in effect. The first, and I think the most important, is that I think a lot of agents And a lot of people assume first that the only providers in network are University of Utah providers. And the second point is that University of Utah now has all 4 major hospital networks in network. Before AEP, and ever since they began, they've had the 3 hospital networks in. So they've always had Mountain Star. They've always had University of Utah. They've always had replacement for IASIS. If somebody could remind me, it's not coming to my mind. I got old brain right now. And they announced, University of Utah announced, it was like the 3rd week of October or something, that they now have a contract with Intermountain Healthcare. So that means that University of Utah has all 4 provider networks in it. So they're in the same boat as UnitedHealthcare, the same boat as Regents, and the same boat as Humana's PPO. And so I think that if people knew that they have one of the best provider networks, which is the University of Utah, one of the best ones in the country, and that they have all 4 in there, maybe things will take off. And I just don't think that agents know about that. I'd be interested in hearing what agents think about my thoughts.
Well, Doug,
But-
hey, were
yes.
you, as far as the hospital networks, were you trying to mention IASIS along with Mountain Star and IHC?
Yeah. So who bought IASIS? I mean, it was bought by Steward, and then
I'm not sure.
and they put the Bob showed us that they put 5 hospitals up for sale here just a couple of weeks ago. So
Oh, okay. Yeah.
I should know it. Oh,
So one of the things that have come to my mind as I look at this list, my wife and I have cable TV, and have 200 channels, 300 channels, and during AEP, it was constant inundation, as you all probably witnessed, the advertising for Medicare during AEP. By carriers, we're talking carriers and not the Joe Namath commercials. And by carriers, it seems like the majority of the advertising we saw, and I was trying to pay attention to this, was UnitedHealthcare. It seemed like they probably out-advertised everyone else, probably 2 to 1 easily. We saw some Humana, a more human way to live was their tagline. We saw a lot of that, but the one that really surprised me was how often we saw Select Health advertising their Medicare product, and it seems like that they really put a lot into advertising during AEP for Select Health Medicare. Saw a little bit of Aetna. I'm seeing more Aetna right now during OEP than I've seen from the others. I can say I don't think I saw anything advertising on the TV, on cable, for either Molina or Cigna. A little bit, just a little bit of Regents, and nothing for University of Utah. Maybe on the local channels they had something, but on the cable, I didn't see anything else. Did anybody else notice that at all?
Yeah, Humana and UnitedHealthcare, just about all that I see on the stations that I watch.
Well, one of the things in the past, but I didn't notice it so much this year, is it seemed like Humana had a 24/7 channel going on about Medicare. Did anybody see that this year?
Well, Humana, seems like every one of their commercials is an infomercial. They go on and on and on into the night.
Yeah.
For 3 or 4 minutes.
Exactly. Anyway, it just seemed like we were inundated with UnitedHealthcare. My wife and I, we mentioned that to each other several times. And then they were piggybacking with AARP was jumping in there too, talking about med supplements. Let's go to the next slide.
Can I just insert something here? So Greg Nelson had a couple of ideas here that I just want that he chatted with. He said, when you look at the Medicare formulary finder, University of Utah doesn't come up high very often. And he also said, as well, the University of Utah doesn't have a national network like some of the bigger national players. So I thought those were good points.
Yeah.
Go ahead, Bob.
Well,
Can I
just
jump in for a minute here? This is Nancy Kuhn with a comment. I agree with Doug that a lot of it is they don't know what the benefits are. And just as an example on the Papa Pals, I mean, more of them are starting to get it. Molina is the leader with 192 hours along the Wasatch Front on just their regular plan. I guarantee that if beneficiaries were aware of that benefit, they'd be scrambling for it. And I think a lot of them would give up, IHC if they needed to get that amount of Papa hours, because that is huge for people who need them. So yeah, I don't think the agents in general, UnitedHealthcare is the safe choice, and it's what I sell the most of as well. But I just don't think some of the ones that are towards the end there are good at advertising their differentiating advantages.
Yeah,
so Nancy, since you brought up Papa Pals, the other carriers, where are they sitting hours-wise compared to Molina? Do you know?
Well, they're far less. I put my sister on Molina specifically for that this year. Select Health has them. I think it's maybe 20-ish, something like that. Regents has it. But that, 192 hours, that's like 4 hours a week. And for someone like my sister who's wheelchair bound, can't clean her own place. The other thing they'll do, if you don't have a car, on Wednesday, they picked my sister up and took her up for her oncology appointment and waited the 3 hours. Well, it was 3 hours total, but they waited and they took her back. And when she tries to do it through the county services and stuff like that, she's been known to have to leave before the doctor saw her because she has to tell them when to pick her up. There's no flexibility in it. Whereas, the Papa Pals will sit there and wait for you.
So thinking about that and looking at the share by carrier, I'm very curious of all you agents, is that you push products that are comfortable and most familiar to you rather than doing a dive on comparing plan to plan. I'm just curious. And Nancy, you made the comment that you did more UnitedHealthcare. You sell a lot of UnitedHealthcare. Is that because of your comfort level with them?
Well, they're very, very consistent. I mean, all the other guys, their plans change a whole lot more. Seniors, I believe, like consistency. And if UnitedHealthcare makes a change, it's likely going to be in favor of the consumer. And some of the other guys will lowball it to get in and get market share and then have to pull back and all that kind of stuff. So I would say they're consistent. What I don't like about them is if you don't call the right 1-800 number, it's next to impossible to get to the right person. They're huge and bureaucratic from that standpoint. But especially, on the DSNP, when they get assigned a navigator and a person that they can call, I have, as an agent, what I want is happy clients because that's how I get my referrals. And I just don't have complaints to speak of for, relative to how many people I put on them. I think UnitedHealthcare, I haven't done the numbers in a long time, but I don't get any complaints from them. I don't get any complaints on Select Health. I don't believe I have on Regents, but it just, they're the safe choice. And again, the number one issue is networks, and they were the first to have all 4 networks. Even though, as we've mentioned, Select Health and University of Utah, I just don't want the network. I just don't want the customer sat issues that you get from some of these other guys.
Great. Let's go to the next slide here. This slide kind of shows what the market space is doing. And if you look at that, you can see the MAPD is actually growing. It's increasing. Whoops, I just lost my speaker notes. What happened? Doug, help.
So Bob, hold down your Alt key and go to the tab, and it should bring it back up. I imagine you just shifted focus off of it.
Okay, it didn't work. That didn't work.
So you closed down the speaker notes?
No, I didn't. I don't know what I did, to tell you the truth. Let's see. What are you seeing on the screen right now?
Just the slide. We're seeing what we're supposed to see.
All right. Well, I'm not even showing the slide on my
I'll say, so go back to oh boy. Yeah,
All right.
that's a good thing to do. Yeah, just start over.
All right.
Okay.
There we go. What are you seeing now?
No presentation, just seeing your beautiful face.
Just you guys.
Okay. You're not seeing any slide right now?
No.
All right. I'm getting there. Hang on. Be patient with this moron. There we go. Let's go back to sharing, I believe. Here we go.
There we go. It's coming back up.
All right. I'm not showing my speaker notes though, Doug.
So you did open the speaker notes?
No, I did. I just went back to the tab. I don't know what happened, but I lost everything. Woo! Well,
Okay, so do the Alt tab thing and see if you can see the speaker notes open.
no, what are you seeing now? I'm curious.
We're seeing what we're seeing just the slide presentation.
The first slide that showed.
Yeah, so we need to go back. Let me just look at the slides here. So we need to go down 11. So if you could do page down 11 times.
All right. Well, it's not doing that. Okay. Open with Google Docs.
So one of the things we can do here, Bob, is I
Keep
can watch
discussing.
one of the things that I can do here is I can watch what you're saying, and I can watch the speaker notes, and then if you're not saying something, I can just jump in.
All right. Now.
So do page down 11 times.
It's not doing it. It's not responding.
Okay, so what if I take over the presentation and you tell me what to do?
All right. Take it. So I'm going to go back to.
You stop presenting. You stop presenting.
I did.
No, please stop presenting.
Okay. All right. There we go. Now what are you seeing?
Seeing everybody's face, and now I'm gonna present.
Okay, great. Sorry about that.
There you go.
Okay. So you guys are gonna see all the secrets here.
You're gonna who's Gringo over there?
That's JE.
I don't know. Who was that you were making out
And
with?
that was my beautiful wife, Petra.
Well, where'd she go? Bring her back.
Yeah, I know. She will be right. She normally is right there, but thanks for
right.
noticing.
So here's our next slide. Medicare Advantage. It's increasing. As we saw the previous slides on each county, it is increasing. And this is, this is a state number here, Utah State. It is Medicare Advantage is increasing. Medicare Supplement is staying level. Original Medicare, people who are just on regular Medicare, is decreasing. Group health and retirement plans, 18% of the marketplace, and it is increasing. Now, I'm curious, why do you think the change, or why we're seeing original Medicare decreasing? I think it has a lot to do with the commercials we hate to see on TV. They're bringing more notice to the consumer about Medicare Advantage, that there's additional benefits that are available. Any other ideas out there?
I think there's a big word of mouth play there.
I think
Older people, they belong to clubs, you know, they're going to the county recreation centers, they're all talking, comparing notes, and I think that's got a lot to do.
Yeah, the $0 plans end up being cheaper if you factor in the 228 Part B deductible.
Yeah,
As long as they're healthy. Yeah.
I think a lot of people who are, I talked to a couple up in Enoch here about, I'm right during the last week of AEP, they got my name from someone else and they wanted to talk to me, and they were on original Medicare. And I think talking to them was, they didn't have an idea anything out there was available. And they were, I thought they were pretty up-to-date people, but that it was like they thought Medicare, we've all heard this, you've all heard this, people don't understand that Medicare Advantage or any of those are part of the Medicare or under the Medicare umbrella. For some reason they have it in their head that it's something that really isn't part of Medicare. I've heard that many times over the years. You have to be able to explain that Medicare Advantage is under the Medicare umbrella. But it kind of surprised me that they had never heard of anything other than original Medicare. They got my name from it was the wife's sister-in-law that I had worked with down here in St. George. And they told me, hey, you need to talk to Bob. There's a lot more out there than just original Medicare. Next slide, Doug.
Coming.
All right, there we go. This is Medicare Advantage share by market segment. Again, MAPD is 82% of the market share. Is level. It's growing, but not enough to jump that number up. But it's 82% of the market space. MA only is increasing. I personally think that's because carriers have made a big deal about honor plans. I think that has that's getting some traction. In the past when I talked to people from TRICARE, it was kind of like this could be kind of a scary thing with your TRICARE for life. But I think there's enough education out there with agents as well as consumers. I think that's why that MA only is increasing.
Hey, Bob, can I ask a question? Sorry for stopping you there. There's a
Sure.
heck of a lot of acronyms, and I'm trying to learn everything. If you could, when there's an acronym, maybe say what it is one time, and then we go back to MAPD.
Sure. So when we say MA, we're using that as Medicare Advantage.
Sure.
MAPD is Medicare Advantage Prescription Drug Plan.
Okay.
Right?
Yep.
MA only means it's Medicare Advantage, but there's no prescription drug plans with that attached. So if you're doing MA only, you have to figure out a way to cover them for their prescription drugs, which might be a Part D standalone, or potentially they're getting their drugs through the VA, for example. DSNP, DSNAP stands for Dual Special Needs Plan. Those are people who are Medicare Medicaids. A C.
Bob,
Go ahead.
Cynthia just is asking if this is Utah State only.
Yes.
You were breaking up real bad for me.
Yes,
was
it
that?
is. It is. This is Utah only. Well, no, this particular slide on market share, this is a national number.
That's right. Now, one thing, the CSNP, the next one, CSNP, means for chronic special needs plans. That would be maybe in some states there's a plan just for diabetics. Okay. or someone just with some other COPD maybe. The next one is ISNP. That stands for institutional, someone in an institution special needs plan, like a retirement nursing home type of facility. Now that is both CSNP and ISNP. I've been seeing from different carriers that they are looking at bringing in CSNP and ISNP into Utah. Has anybody else seen that? Any word on the street about that?
Yes, there are. So there is a CSNP plan available from UnitedHealthcare. And I can't remember which counties it's in. I know it's in some of the Wasatch Front. There are a couple of ISNP plans, but they are really hard to get appointments for. You almost have to have an into the carriers so that they'll appoint you. It's sort of I don't know, it's sort of a sweetheart deal, you know, it's cronyism in the ISNP market as far as I can tell.
Now, I have been talking a little bit with Zing Healthcare. They're the ones who bought Lasso, the MSA, which we'll talk about in a second. But Zing has specialized in that DSNP, CSNP, and ISNP market. And I wouldn't be surprised if they start introducing that into the much bigger footprint that they have now. The next one down is MSA. That stands for Medicare Savings Account, which is an easy way to identify that or to define that would be it is an HSA, Health Savings Account, for people over 65. And an MSA, if you're not familiar with it, it is where the feds, through Lasso Healthcare, which is part of Zing, they give the beneficiary or the consumer a credit card preloaded with either $2,000 or $3,000. And there's to use that for their health care. They'll have on the $2,000 contribution, the plan, then the consumer has a $5,000 deductible. But if they use it correctly, $2,000 of that is covered by the MSA account. The exposure to the consumer, if they use it correctly, is $3,000, which makes it realistically, if you think about it, probably the smallest max out of pocket in the market space. Anyway, the MSA product is decreasing in penetration, so to speak, of the market segment. I think there's several things contributing to that. One is Lasso was acquired by Zing Health out of Chicago, and I think, or out of the Midwest anyway. And they did a very, in my estimation, a very poor job of advertising that and trying to explain that. I think the other part of that are most agents don't know it well enough to feel comfortable with the product. Any other ideas about that? Next. Oh, go ahead.
I was going to say I do, but I don't want to say anything bad about the management of the plan. So,
all right, next slide. This is the next few slides is an OEP review. And the thing you need to realize is we look at these numbers and graphs that you're going to see. They're a reflection of the 2022 OEP because, of course, we haven't gotten to the OEP this year, to the end of it. So those numbers aren't out there. So the numbers in the graphs you see are reflective of 2022. Doug?
Yeah, and I would just like to mention here, we're seeing quite a large shift in beneficiary behavior during OEP. And I think that it is talking about or trying to advise you as agents to pay much more attention to OEP than you have in the past, especially on the defensive side of the ball. I think that if you don't start working almost as hard during OEP, maybe not quite as hard as you work during AEP, you're going to quickly find that your book of business is eroding. And I think Bob is going to be going through some of those things.
All right, next slide. This is awareness of OEP, and I was told that this, the slides you see are based on surveys between 2,200 consumers and 2,500 consumers, depending on what we're talking about. So the number that I think this is really interesting. If you look across the bottom of the screen, you see the year 2019, 2020, 2021, and 2022. So if this is an awareness of the consumer of OEP, back in 2019, it was 67%, but in 2022, it was up to 84% of consumers were aware of OEP. Now, one of the things that jump out at me is one of the compliance things that CMS pushes to us agents is we are not supposed to actively, what's the right way, right word? We're not actively to promote or market OEP, but you know, I've been seeing advertising during OEP on cable TV. So I'm trying to figure out why is it that we as agents are being advised by CMS we can't market the OEP opportunity.
Bob, you've seen advertisements mention OEP?
No, I see them advertise that if
During OEP.
Yeah, they're just
during OEP that they can make a change.
yes, and they can, right? If they have an SEP, they don't say that. So I've been listening quite closely to those advertisements, and they're not even mentioning OEP, and so they're completely legitimate promotions, as far as I can tell.
But I think it is targeted towards OEP consumers, though.
Well, yeah, but it certainly, if a consumer calls in, they don't need to find an SEP.
Right.
They just have the OEP, but they're not saying that. They're not getting people to call in by saying, hey, do you know that you have the ability and the right to change between January 1st and March 31st? They just know, the advertisers just know that they can do that if they can get these people to call, but they have to do that without mentioning the OEP.
So it'll be interesting to me to see after March 31st what happens to the Medicare commercials.
Yeah.
They should remain the same, right?
They should, but I'm just thinking out loud here. I would be surprised if we don't see a real decrease in advertising over cable TV of Medicare.
Oh, you're just talking about not the change in the content, but the change in the frequency and the reach of the
behavior of those who are doing the advertising.
Yeah. I think you may be right there.
Okay, next slide. So, percentage of consumer shopping. 78% of all consumers out there didn't do any shopping. 16% shopped, but they didn't make a switch. 3% switched carriers, 3% switched plans, and no one dropped and went to original Medicare. But it is something that you need to be aware of, that that number of people shopping is increasing year to year. So it's just more to emphasize that you need to have a relationship. So if someone is shopping, they call you first to ask you for your opinion. Next slide.
Well, you got some speaker notes here, Bob, so let me just jump in here. So one of the things that you noticed is that in 2022, the AEP saw about 44% of the seniors shopping or switching. So almost half the people who were enrolled in an MAPD plan are actually actively looking at it during AEP, even though they compare it to having a wisdom tooth extracted. And that number, the interesting thing is, and I don't know if I doubt this will hold, but the people who are doing that during OEP is 22% in 2022, right? So it's exactly half of the people who are actively seeking in AEP, the annual enrollment period, are also shopping and looking during, half of them are looking during the open enrollment period. And JD, you and I can talk about this, or someone can talk about, again, we're throwing acronyms out here. Sorry about all the acronyms. Basically, AEP is the annual election period that happens from essentially October 1st to December 7th every year, when people choose their next year's plan. And the OEP is from January 1st to March 31st, where someone can say, oh, I made a mistake and I need to change it if they're already in a Medicare Advantage plan.
But I'm for sure gonna chuckle and laugh every time I hear ISNP. Sorry.
Okay.
All right, switcher numbers. Of course, I need you to pay attention to the color coding here. The kind of turquoise color is did not shop. The next color, a little bit darker, kind of a purple, shop but did not switch. And then the red one is switch plans or carriers. So if we look at this again, and it's by year across the bottom, 2019 all the way up to 2022, you'll notice the one that jumps out at me is 6%, that red line, 6% switch plans or switch carriers. So we'll have a slide later on that will show what consumers are saying, why they switch. But I think this is an interesting plan to see that that top line, did not shop, is decreasing. So you want to make sure that you, again, all these slides, I think, just emphasize the point that you need to have an ongoing, up-to-date, current relationship with your clients.
So Bob, you've got a couple of notes in here. Can I just?
Absolutely, because I can't see those. I can't.
Yeah. So I'm looking at the speaker notes that you can't see and tossing them back in. So one of the things that the analysts are looking at here, and by the way, most of these numbers come from DEFT Marketing. They are the marketing research arm of Integrity Marketing. They are noticing that what is happening, even though the numbers of switching during OEP remain low, there is a constant increase in the rate of people who are shopping it. And they believe that this is happening because of the increased marketing, something that Bob was mentioning just a second ago. Agent focus or agent efforts to do it, marketing from third-party marketing organizations, and then they do call out also the celebrity commercials. They think that those are being successful, and so the number of celebrity commercials are on the rise as well.
Next slide. There we go. Preventing rapid disenrollment should be a priority. So this is more shopping, OEP shopping and switching behavior. The purple line is AEP switchers, or people who switch plans and carriers during AEP. And the orange or kind of yellowish line is AEP non-switchers. Now, this is also going by people who shopped or didn't shop. So if you look at that first line, did not shop, 81% of those who did not switch did not shop. I think that has to do with agent involvement again. I think if people didn't switch during AEP, I think number one, consumers were happy with their plan. And I think switching plans, I think that's a tough thing for most seniors. I know when I personally talk to my own clients, which is a very small book of business, the first thing I ask them when we sit down together is I ask them how satisfied or how happy they have been with their plan. And some are very adamant about, man, this is great. I never knew my health insurance or my health plan could be so great. So the last thing I want to do is switch switch them or talk about something else unless there's something really, really important that I feel like they need to see. Anyway, we'll go down the next line, shop, but then did not switch. The numbers speak for themselves. Anyway, we look over here and see that 27% of AEP switchers reported changing coverage again during January to March open enrollment period, meaning that 27% of the people who switched to a different plan during AEP changed again during the OEP. I thought that was interesting. And I was trying to figure out why that would be. And I couldn't come up with anything other than that they're open to switching.
So, Bob, and you don't have a note here, but this is something that was occurring to me. And we're going to be looking at a few slides in a minute that have some information. And I thought I might, what's the right word, interpret those slides beforehand so that when you get there, you look at them maybe a little bit differently. So one of the conclusions that is coming, and this isn't a black and white thing, this is sort of a gray thing, and it depends on how much. I know that a lot of you agents, even agents on the call here, spend quite a bit of time and effort at the beginning of AEP, reaching out and calling to each of your clients during AEP to make them know that you're aware of them, that they have someone that they can call, right? One of the conclusions that is coming out of this data, and it's coming out of it to me quite clearly, is if you want to protect your book, you're going to want to consider making the same phone call campaign, say at the beginning of the year. So once a OEP has started, the open enrollment period has started, calling out and talking to people. Now, the data that are coming are going to show a couple of things. One, they're going to show that if people have had some type of health crisis and they are facing increasing expenses because now they're more likely to shop. That's completely reasonable. But that means that if you keep in touch with your clients and you're vaguely aware, with HIPAA compliance in mind, of their health situation, you know that if they've had a diagnosis or if they're in some type of crisis, that they're going to be more likely to switch, and they're going to be more likely to be paying attention to the TV advertisements and things like that. So you may want to devote more attention to them. The second point that they're going to be making here in some of these slides is that people who make a switch in plans, and they don't say this, but this is my interpretation, after Thanksgiving and before December 8th, those people who make that are going to be more likely to be switching during the OEP. And so I've been asking myself, well, why is that? And I think that what's happening is people who make the switch after Thanksgiving are feeling like they were rushed and that they didn't have a chance to make the decision with as much composure as they would like. And so after the 7th of December, with the 87% awareness now of OEP, they continue to shop and think. And then when OEP comes, these people who made an election after Thanksgiving and before the end of AEP are much more likely to make a new election during the OEP. And so I just wanted to mention those two things to get you guys to thinking about how to change your behavior, because I think these slides are suggesting a number of ways that the environment is changing and that agent business owning behavior needs to change.
So Alexis asked the question, people who, do we have any numbers of people who switched during AEP, then OEP went back to the original plan? We might see some slides that review that a little bit, but
You'd have to read between the lines. That
Yeah.
there were no slides that talk about that explicitly.
okay, so we're looking at OEP trends. OEP switch rate by AEP switching behavior. So this kind of addresses a little bit of what you were talking about, Alexis. We're looking at again 2019 through 2022. This is people who switched to OEP during, and also switched during the AEP, if I read that correctly, Doug.
I'm sorry, I was reading the notes that you have here so I could make a comment. I wasn't listening to what you said, Bob.
Oh, that's all right. That's all right. Go ahead and go through the notes.
So one of the things that the statisticians are noticing is that the people who switch plans during AEP are the people who were likely to switch plans during OEP. That should come as no surprise. I think that one of the reasons that so many people, 78%, if I remember right, stay pat with their plan is they just don't like the complexity of trying to figure that out and having to think about that. They just prefer not even to think about that. So those people who actually jump the hurdle of thinking about that, whether they're pushed because of their health going south or because of rising costs or because of declining income or whatever that is, those people have to think about it and they're willing to do that. They are also pulling out subpoints in this. So they talk about some of the what's the right word here? Some of the influences in the marketplace that affect decisions are that Medicare supplement benefits are continuing to innovate, and they're trying to come up with flexible offerings to reverse the decline in the penetration of the Medicare supplements. They're also talking.
Go ahead.
They're also talking about the prevalence of Part B givebacks throughout the country. They're becoming more common. They're also talking about the fact that, and I didn't know this, I'd be interested in figuring this out. It looks like when Select Health received its 5-star rating, a number of other plans also received 5-star ratings. Consequently, there are quite a few more 5-star rated plans in the country now than there have been in the past. And it looks like, as I'm reading between the lines here, though I was listening at the beginning when you guys were talking about who is advertising and which carriers are advertising during OEP, it sounds like the guys who have a 5-star rating have an ability to do advertising and say things in advertising beyond just the 5-star, but they have other liberties in advertising that the non-5-star plans just don't have. And they are going to be, there was a program at CMS that allowed carriers to basically select either this latest year's ratings or the previous year's ratings on which, no, the carriers were allowed to select which of the measurements CMS did on them either this year or last year that they were going to use to affect their star rating. And that contributed, it looks like, to more of the plans getting the 5-star rating because they could sort of cherry pick between 2 years and they could choose the very best of the 2 years to be considered for both years. And so more plans got 5-star ratings. It looks like that program is going to be discontinued and carriers will have to live based on what their latest performance was. And they're thinking that's going to be affecting some of these OEP trends going forward, if that makes sense, Bob.
Yeah. Larry made the comment a few minutes ago that it appears that he had some who switched during AEP. He said some of mine did. They felt like they were tricked, and then they called me. We're going to see a slide down the road that is very interesting about people feeling like they were tricked and moved without their knowledge. We'll see that in a few minutes.
Yeah, and Congress is, especially the chairman of the Finance Committee, is very aware of this. I don't want to say that again for the sake of repetition.
All right, next slide. So time between switchers and AEP and OEP. During October, these are people who switched. We're just talking people who switched, might have been a carrier, might have been a plan. But the thing I think is interesting about this is that the people who switched the most were people who came into AEP and had made a switch during AEP, and then once OEP came around, they switched again. And it was those who enrolled late during AEP. Is that what the notes say, Doug?
Yeah, and this is where we were talking about it, and I wanted to bring this up where, so if you are talking to members of your book of business after Thanksgiving and they switch plans, you should make a note of that, because these are the people who are more likely to switch again during OEP. And so definitely these people, if you take note of it, they're definitely some of the first people that you want to reach out to in your phone campaign for OEP. So you might want to reach out to them in January. And certainly if I were running my own business, I think that's how I would do it.
All right, next slide. All right, this is one that was a real eye-opener to me. Consumers were unaware of a plan switch, and we've heard of this on the street happening, but this is the first time where I've actually seen it being discussed by someone who's done some research, meaning deft research. Percent unwillingly switched. I think this is very, very interesting. It's 20%. Unknowingly, if over on the right hand side you see unknowingly switched during AEP, did not shop but did not switch, and then switch carriers. Just those numbers. What do the notes say, Doug?
Yeah, so most of the notes here are talking about the statistical significance of this particular study, and all of the statistics they feel are significant. And this is some of the stuff that is causing Congress to be aware of it and is causing Congress to put pressure on CMS. And so a lot of the increase in regulation that you as agents have felt about, call recording the entire chain of enrollment, and making sure that whenever you talk to somebody over the phone or virtually that you're recording that, you're storing those recordings for 10 years. I'm just going to go into a little tangent here. I'm getting a lot of pressure. I'm spending over the last 2 years, I'm spending more and more of my time doing audits. I have an audit that I have to do this afternoon before my workday is done. These things are all going into making sure that you do the call recordings, and they're doing the call recordings. CMS is insisting on these call recordings because they're getting pressure from Congress, who are looking at these particular statistics. And so these are a big deal. They're affecting you even if you don't know that they're affecting you. They are going to be changing your life quite a bit further. Yeah, that's all I have to say there.
I think that 20% is a real eye-opener.
I do too.
People who didn't know they had switched.
Yeah, so what it says here is people are receiving 1 in 5 MAPD members report receiving onboarding materials outreach, including member cards from a carrier with whom they didn't even know that they had enrolled. So that means from Congress's point of view, 1 out of 5 or 20% are illegitimate transfers of beneficiaries from one carrier to the next. And that's horrendous. So that's what Congress is seeing, and that's why they're putting all of this pressure on us to start recording doing all this stuff.
Yeah, I got a comment on that. I had a client that was switched, said she didn't know it, yada, yada. We turned them in, had them pull the call. The woman is in her 90s, and the call checked out fine. So, 20%, I would like to see what the age breakdown is, because we know that half the people over 85 have got dementia issues. I think, it's not a good thing. Obviously, it's an issue, but I don't think it's 100% unscrupulous agents doing it.
I would agree with that. I would agree.
Yep.
But
Just
Congress probably isn't making those subtle distinctions.
I think this slide that we're looking at is really interesting. I never realized this personally, but what it's showing is that 33% of the beneficiaries who are on a plan used their plan the first half of January, 22% the second half of January, which means 50% of the beneficiaries out there use their plan in January. Now, that lends, I think, a little bit to the OEP numbers is you've got half the people out there who are using their plan in January, and maybe what happens is they don't, until they use their plan, they don't realize maybe some of the things they either lost or wish they had. What do the notes say, Doug?
Well, so it's basically confirming what you said, but what it's suggesting, and the reason it's suggesting, though it's not clear that that's what it's suggesting, is that Medicare beneficiaries, when they're changing plans, are sort of testing out the new plan. It could be that they're actually finding reasons to use the plan in January, and it probably pertains to the growing awareness of the OEP and what that means for them. And so they're testing this stuff out. And that's the behavior that we haven't seen, but at least I'm not aware that we've seen that before, but that appears to be happening. And so I'm actually anticipating, and I can't remember who suggested that they're talking to each other at their clubs and their bridge games. But I'm anticipating that we'll see this trend continue. It'll continue to rise.
One thing over on the left-hand side, you see 85% of beneficiaries use their coverage. I was shocked at the number who don't use their coverage. Essentially 15.
Bob, just a quick note on those who switch. We've been kind of talking about it. I had a client, she'd been on one of our plans for years. And later, when we went back to see her during AEP, she had a different plan. And so I was talking to her about that. She was switched by one of the ads on TV, called in. She did not realize that if someone else signed her up for a plan, that we would no longer be her agent. And so just a misconception there. And I said, Phyllis, you've been signed up by somebody else. You're on a different plan. I'm no longer your agent. She said, oh, I can't have that. I mean, a good story did come out of it. We did switch her back to another plan that was just as good as the one she was on. But she thought because we had all the carriers listed that no matter which one signed her up or whatever, I would still be her agent. So it's just kind of interesting. You can't always assume something, and that's having a good relationship with your clients. And she'd been with us for years, but interesting, we got her back, but shouldn't have happened in the first place.
Thanks, Paul.
So there's one thing you need to understand. I just see this. Cynthia said are using the plans for RX and medical. They keep, just because a beneficiary switches plans during OEP, that does not restart the clock on their Part D portion. CMS keeps track of that along with the carriers, and I have ran into people over the last year or so who switch plans during OEP with the idea they had it in their head that started their prescription drug coverage over, and it doesn't. So this slide is beneficiary needs and agent's duty. This is perceived nearly 70% feel like the plan was the best fit and that it fits their current needs. 26% a good fit, but some of my needs may not be met. And others, 4% an okay fit, but there are gaps in my insurance coverage, and 1% bad fit. My coverage doesn't meet my medical needs. What do the notes say, Doug?
So it's just highlighting that means that if you're thinking about your own book, 30% of the people that you've had a conversation with are still feeling uncertain and are still likely to feel impelled to shop if the pressure goes up on them for those reasons that we've already talked about.
Now, I think it's a positive note to also look at this slide and say 70% feel like it's my best fit. And I think that's a direct relationship to agent relationships. They trust you. You're a local agent. You're a local, you know the local plans, and you are a local expert in the plan. So I think that's a positive. Of course, we can see the negatives here, but I think 70% who are very satisfied, I think that's a direct result of agent interaction. Here we go. Reasons for beneficiary dissatisfaction. I thought this was really interesting. You'll see a line about 3/4 of the way through this graph, and that there's an interesting breakdown there. But first of all, 30% were dissatisfied because of the dental coverage. 25%, nearly 25%, were unaffordable prescription drug costs. And I know we all run into that. And it's kind of like, well, what can I do for you? Kind of that's the way it is with prescription drugs, unless you're looking with your doctor, looking at some sort of a generic drug you can use. Does not include my established dentist in the network. I think that number, I see that as I talk to broker reps, that the dentist network is expanding dramatically with carriers. 19% does not cover all my current prescriptions. Again, I think we've all seen that. Now, I think this line is interesting in that those 1, 2, 3, 4 top things are things that are happening right now that they're experiencing. And when you go below that line, you're looking at comments consumers made about the future. Now, like the very first one, does not cover my drugs or treatments I'm likely to need in the future. Does not cover services I may need if I develop a new health issue. I think these are all future concerns. I like the one down there at 15%, does not include benefits that will help me age in my home. I think that's a Papa Pal discussion. I think the monthly premium is not affordable. I think that is from lack of agent interaction, maybe in explaining the premiums. But I think that was interesting that the top 4 were things that are happening right now, and the bottom ones were things that people were anticipating or were fearful of. Doug?
Yeah, so I think what this does, having this particular list here and being able to understand the relationship of these items between themselves, is it probably should be affecting your presentations, what you're saying, the content of your delivery. So when you're talking to people on the phone, you're talking to people face to face, what you're doing is you have these things in mind and you are adapting and you are probing to find out which of these concerns is their concern, and then you're addressing that. And I think that is part of what you need to do for AEP, and it's certainly what you need to do to keep the retention high during OEP, which is becoming as you've probably seen, is becoming a greater challenge for you. And I know I've talking with agents on this call, on this on this meeting who have expressed frustration with the number of clients that they've lost because of some of the practices during OEP that we're discussing right now.
One thing I thought was interesting, again, I meet with the carrier broker reps quite often. And one of the carrier reps that I was meeting with within the last few weeks, we were talking about their enrollment numbers during AEP were level, flat, or I'll say we're losing just a little bit. And the first thing they brought to my attention was we need to increase our dental benefit in 2024. So they recognize that. They recognize how important dental is, and that's the number one thing seniors are asking for when it comes to looking at plans. Next slide, Doug. Cost concerns like inflation drive switching. So this is just, again, this is what consumers are perceiving down the road. And one is the light green color is they're very concerned about inflation and how it will affect them going down the road. And then the dark turquoise or dark green, 87% did not shop because they were not, that inflation part wasn't in there, so to speak, I think. And then you're looking at shop did not switch carriers, switch plans. Again, this is based on cost concerns like inflation driving switching. Doug?
Yeah, so I just want to point out that, and I know that this number that I'm going to throw out there is going to be controversial, but right now, let's say that the inflation rate is 7%. That means without spending any money at all, if they're not spending any money at all, they're seeing their savings, the value of their savings decline 7% per year without spending anything. And they know that they're spending something. And this is causing anxiety. And because a lot of them are on the fixed incomes, you guys know all of this. But that means that we're going to see, as long as we're in this current economic situation, and at least the economists that I'm following seem to suggest that things are probably going to become more challenging down the road, which means that you need to be reaching out and, what's the right word here, comforting your book of business probably more than you have in the past. Anyway, that's just hopefully food for thought.
Next slide, Doug. Effective OEP promotions. I think this was a very interesting slide. Receiving promotional material from another carrier. I routinely get that in my mail. Other carriers, I get a lot, and I don't mean to call out, but I do mean to call out. I see most of the promotional material that I get in the mail is either from AARP or from UnitedHealthcare. I don't see so much. I've seen a little bit from Select Health lately, but I'd say the majority of the promotional material coming to me in the mail is from AARP or else from United. Next one is seeing a health insurance TV advertising. I'm seeing more and more, and you probably are too, of carriers promoting their plan through TV advertising.
Mm-hmm.
Number 3 is seeing general TV messaging about Medicare, not from an insurer. That would be the Joe Namath commercials. Again, that's 28% of the promotions out there are coming from those people.
So
Go ahead.
Well, I was going to just jump in here and say things that this was a little. This slide was a little eye-opening for me, and let me tell you why. Notice the first two have to do with insurance carriers doing the advertising. people, it looks like, are more affected by insurance carriers doing advertising than they are by agents or call centers doing the advertising. Those guys don't get, you don't even see the insurance agents and call centers until line item 3. So the first 2 ones are the insurance companies. Now, it happens to be right now, so the most effective, what this is suggesting is that the most effective promotion that you can do would be in conjunction with a carrier. I mean, it's not 100% that that's the conclusion, but that's a strong inference that you could make. There's evidence to that effect. But what that means also is, in this new environment that we're in, is if you're going to do that, you either would have to use the canned stuff that the carrier offers to you on their website, and there's evidence that that's questionably effective because, you know, you can't differentiate yourself from other agents. And if you want to differentiate yourself, that means that you are going to actually have to submit advertising to the carrier, get the carrier to go along with you, but then also submit that to CMS through HPMS, their marketing database, to make sure that you have a code on there that says that it is a registered marketing piece according to the definition of marketing of CMS. And now they have a definition of marketing that is both content and intent related. It has to have both in order to qualify. And so many of you that I've been talking to in the past, I have said, look, what we want to do is we want to try to avoid having to have it approved by a carrier. I've had carriers that have taken more than 6 months sometimes to approve marketing. We'll send marketing in. They'll make changes, we'll make the changes, we'll send it back, they make more changes, we make those changes, we send it back, they make more change, and it just dragged out for more than 6 months. And so I've had agents who say, I don't have to put up with this, I'm not going to do it. And one of the things that I've been doing is I have been telling people, look, you can craft advertising and promotional materials that do not trigger the CMS definition of marketing, and you can still do that. You can advertise yourself, you can advertise your agency, you can talk about managing and simplifying or non-complicating their Medicare decisions. None of those things are actual official definitions of marketing, and you can still do that. So you don't have to submit to HPMS at CMS, you don't have to submit to the carriers. But notice what this is saying. This is saying that those particular approaches to promotion are not as effective as they used to be. So it's looking like those people who were willing to tackle the complexity of engaging with carrier compliance departments and with CMS compliance regulations have a larger chance of having their advertising and other promotions actually be effective. So this is just more evidence of how the environment that we have been in, that we've been enjoying over the last several years, is changing. We're going to have to start engaging in activities and in managing the complexity of the system more than we ever have in the past. At least that's the conclusion that I'm drawing. And we're certainly willing, if you want to discuss this, to help with that.
Cynthia is asking the question, is all this data MAPD data, or does it include supplements? And I think the easy answer is it includes all the coverage under the Medicare umbrella. So there's some here that's just MAPD, but there is quite a bit here that also includes med subs. Go ahead and switch. Next slide. Promotional successes by year. I think this one was really interesting. Is that we're seeing 2020 is the kind of the orange color, and or 2022 is the dark one. So we're seeing that the promotional material from another insurer has grown, and it is probably weighs the heaviest with consumers. Seeing the health insurers TV advertising, that's a real positive. Seeing general TV messaging about Medicare, you see that's increasing, but I think that really reflects a lot of the Joe Namath one, because you go down a couple of lines and you'll see seeing or hearing a celebrity endorsement from Medicare plans. So maybe that doesn't have as big as impact as we all think it has. I'm not sure. The one that really jumped out at me that is a little troublesome when I look at it is the receiving a phone call from a health insurance agent. Now it doesn't. It goes down and it's, it just, that one just bothers me. But I'm thinking that probably includes receiving a phone call also from a client's own agent, because it doesn't differentiate from a different health insurance agent. But that's just that one just kind of muddies it for me a little bit, because I know that's happened. I've had agents as well as clients tell me that they've had other people than their own agent contact them. So that kind of is a little bit bothersome to me. And that all comes down to people don't understand the compliance component of outreach. Doug, what do you have on your notes? Our notes.
This is the slide where the marketers, the analysts said that they're expecting to see changes in the effectiveness of the insurance companies' advertisements, because the insurance companies have been allowed to choose which year's measurements they're going to use over the past 2 years. And now that they're losing that flexibility, if they're going to remain honest in their advertising, which they're submitting their ads to HPMS requires them to do, they're anticipating that these numbers will be a little bit different going forward. So it's sort of like, so the question that I ask myself as I look at this is, okay, if I base my decisions going forward on these numbers, but I can't trust these numbers as much because they're going to be changing, the question that then arises in my mind is how much of my decision making and how much of my change in my management activities is going to depend on this. And I think it still should depend on it quite a bit. I think the changes that we're going to see due to the carriers not being able to cherry pick are going to be rather minor. And so I think that you can look at these things and decide going forward what you're going to do with your promotions. What type of promotions are you going to target? How are you going to differentiate yourself from your competitors? How are you going to be talking to your clients or with your prospects in such a way that you are emphasizing or promoting one of these particular approaches?
Great. Let's go to the next slide. A summary and advice from OEP data. Beneficiaries are shopping more during OEP. We've seen from the slides that number is increasing every year. I think a little bit of that has to do with, as the younger T65s, that I know that's oxymoron. That's not a very good description, but the T65s coming into the market are more tech savvy. We also see that beneficiaries are switching more during OEP than before, and that number is increasing. I think that has to do with people becoming aware that they can shop during OEP. I also saw some data that I didn't include it here, and younger beneficiaries are more likely to shop. I think, again, that goes back to they're more tech savvy. But the thing that we need to keep in mind, local agent, local expert, and that's one thing that you as agents need to promote. The other thing is agent-client relationships are critical to keeping your book of business, but also expanding your book of business and protecting yourself during OEP. Doug, did you have any additional notes on that? Doug?
Sorry, I had my mic off.
That's all right. That's all right.
No, these are Harnoy's conclusions, and you did not put any additional notes in here. So,
All right, next slide. Uncomfortable regulatory changes. What's driving anticipation for changes? CMS data shows that beneficiary complaints have doubled from 221 to 220. From 220 to 221. Sorry, I misspoke. They have doubled. From the initial presentation I heard, the doubling of complaints, they could point their finger directly to the TV advertisements that they see that are driving people to call an 800 number. Congress and CMS are concerned about the tactics for marketing Medicare. These tactics include deceptive advertising, misleading claims about increasing Social Security benefits, and we've all answered that question, I know. Aggressive in-person sales tactics and enrolling beneficiaries without their awareness or consent. Congress is pressuring CMS to fix these problems. Any discussion?
yeah, I want to jump in here. Again, you guys are probably sick of hearing from me, but a lot of the problems that we're seeing here are a direct result of the large online call centers and the fact that they had taken their marketing departments and spun them off as third-party marketing organizations that were free from the regulation of CMS. And so CMS is having to get those things under control, and they have instituted these new regulations, in 2022 that went into effect the 1st of September, 1st of October, I can't remember which. And they are rather burdensome to you. They are having an effect. And the effect is that the call centers, they're stocked, and there's some other measures that CMS took that may even be more difficult for the call centers to handle. But their stock prices are declining, their revenues are declining, their stated revenues are declining dramatically. They are laying off. They are laying off employees. Some of those employees are entering the market now as independent agents, not large numbers, but the ones that are entering are really skilled, and they are coming into the marketplace. And we're anticipating that things are going to continue. At least I'm anticipating that things are going to continue to change. The changes that are occurring due to this administration are occurring much earlier in the administration than it did either during the Trump administration or the Obama administration. I actually have the feeling that the administrators of CMS came in and they knew what they were going to do even before they came in, and they are moving on it. And they are moving on it in such a way that they are paying much more attention to Congress than they're paying attention to the other lobbyists like AHIP, the insurance carriers, or the insurance agents like us through our organization that used to be called the National Association of Health Underwriters and now is called NABIP or something. I can't remember what it's called. I should. I'll have to remind myself after the call. But things are going to be changing, and as long as Congress is putting the pressure on, and as long as someone is as high pressure, and we'll see his name here in the next slide, is putting pressure on CMS to change these things, I think that we can anticipate continuing to see this type of of pressure, and we can anticipate more uncomfortable things coming down the road. I'm not sure how uncomfortable, but I'm anticipating a few of them coming.
Next slide. So what's driving regulatory changes continued? This is from Senator Ron Whidden, who has some oversight with CMS. I looked him up. This is a quote from him. "I strongly support the proposed rule as it seeks to restore important protections against deceptive and fraudulent marketing tactics. Expands access to non-physician behavioral health providers and promotes health equity for historically underserved communities." He's talking about some of the things they're trying to expand the Medicare provider network here. Medicare,
So Bob,
yeah.
So if I could just again make this more relevant. So the way it affects our agents is, this is also the rule that he's talking about that requires our agents to record the all events in the chain of enrollment, and then to store those for 10 years. It is also the rule that's required, that is requiring agents to submit their customized advertising and promotional materials to CMS to get the SMID on those materials. So these rules are impacting you already.
So it's interesting that they acknowledge that 30 million people, nearly half of 65 people with Medicare coverage, this affects. He also released this statement from his report in November. They said, this is him again looking deeply into some of the complaints coming into CMS and responding to that. He said he found fraudsters and scam artists running amok in Medicare. I think we have seen that on a local level with some of the people we deal with. He says targeting older adults with deceptive Medicare Advantage marketing practices. I believe he's talking specifically about the celebrity Medicare commercials we see driving people to call the 800 number. Cynthia is considering bringing back the 48-hour rule for 224. Yes, they are looking at that. They're looking at other things too, but they are looking at that. How soon before face-to-face meetings need to be recorded? Right now, there's not a push for that. From what I've talked with some of the carriers and some people who are very big into working with CMS, they're currently not they're not looking at recording face-to-face meetings, but they are looking to strengthen the disclaimer portion of it and possibly making the disclaimers part of the SOA. All right, next slide, Doug. Where's our marketing opportunities going forward? I've seen several studies that show that the telemarketing people outperform agents with the SEP. And I'm not sure how they're doing that, but that's one area that I think that is a big opportunity for us, is to figure out ways that we can penetrate that SEP market, especially here in Utah, where we see the numbers of people moving into the state. We're seeing more explosive growth in Utah than we've ever seen before. The other marketing opportunity is 5-star. I know Select Health is putting together some webinar information that you'll be able to use to promote 5-star, and it'll be interesting to see how they do that. The DSNP, or dual eligible, that's a marketing opportunity. As we have more seniors retiring and on a very fixed income, I think that DSNP will be an opportunity that continues to grow. The T65 market is still growing. Any comments? No comments. Let's go to the next slide, Doug. CMS points of concern, clarification of telephonic recordings. Yeah, I know I've heard from several carriers from their compliance people that CMS is trying to clarify that face-to-face and service calls, they're going to clarify those, that they don't need to be recorded. One of the concerns that CMS has is provider directories as well as formularies are constantly changing. I just saw a big change with one that I was made aware of yesterday from one of our agents about a big formulary change or additions that UnitedHealthcare was doing. But CMS is concerned about those being updated as well as the provider directories. They're concerned about Medicare education. In the past, or the past few years, it's been if you're doing strictly Medicare education, like Medicare 101, there are some of the things that we do with carriers in the past. Well, let me back up. It's been the last few years, if you're doing strictly Medicare education, you could provide a meal. They had changed that. They're looking at changing that again. The use of the word Medicare and Medicare logos, they're concerned about that. I know as you leave Mesquite, Nevada on the freeway, because I go to Las Vegas quite often to work with some of our agents down there, there is a very large billboard that's promoting Medicare by name, and to call, and I don't know who this person is, says call Medicare Mary. They're going to start chomping down on that, I believe. I know there was an agent I knew up in the Salt Lake area that his business card looked like a Medicare beneficiary card. And I think that's something that they're going to really come after. They are looking at chain of enrollment record keeping, whether it be recorded or it was a face-to-face. That's going to be part of audits coming down the road. And face-to-face solicitation and initial contact of beneficiaries, they're looking at that. They've had a lot of complaints, and CMS is trying to get involved with clarifying face-to-face solicitation. And they specifically said in what I read was door knocking. The other thing is they are really concerned that agents are not using this disclaimer, and the disclaimer use is not being used appropriately. So those are things that I've heard from several of the compliance people with different carriers, are things that they're looking at. I know a person that is a lobbyist with CMS. There are 12 Medicare or CMS countries divided into 12 quadrants. He's quite close to a few of these people who are at the top of the pyramid, so to speak, with different geographical areas that report into CMS. He says there's a lot of discussion about compliance. So, any comments? Can we?
Yeah, what disclaimer thing are they worried about? What are we supposed to be disclaiming?
Oh man, I just lost my screen again. Wonder how that.
So Nancy, there is a disclaimer that they wanted us to start doing in 2022, an additional disclaimer. We actually have put a copy of this out on this generic website called Medicare. Holy cow.
Plan design.
Yeah, plan details, MedicarePlanDetails.com. What this site is we're going to actually put this presentation out there. It is behind a password, even though it does not need to be right now, but it needs to be, up till October 1st, usually from the 1st of August. So we just leave a password there. The password is MA2023 lowercase. If you go out there, we're going to have the disclaimers out there that you need to use. We're going to have carrier stuff out there so you can find the enrollment kits, the summaries of benefits and things out there. or if you guys want us to put stuff out there just so that you have a convenient place to go without having to know how to navigate all of the different carrier websites. This is just a tree of resources. You can go out, you can look, you can download, you can just remind yourself, and we'll put that. This disclaimer is out there if you want to look at it or download it to your computer.
Next slide, Doug.
Okay.
Next slide. Compliance review, elevated record keeping, SOA compliance, permission to call and contact, keep those. They're saying that that's a 6-month. To get a PCT, permission to contact. Why is it PCT? Anyway, permission contact is you need to keep that current and up to date. At least stay within the parameters of the original date. Telephone recording compliance, contact method, and referral compliance. I know that's that referral compliance gets it. That's pretty black and white, except we all painted a little bit gray. I know from past experience with agents. But let's just make sure that we're compliant. CMS is, I think they're going to put more emphasis on compliance. I think a lot of the audits that Doug will be doing will be compliance targeted. And if anyone wants to deal with us as individuals, we need to make sure that we keep good record keeping and we're compliant. Next slide, Doug. All right, summary of your response to changing environment, agent-client relationships, agent outreach, constant contact, post-enrollment service. This is all agent promotion to their clients, trying to protect their book, your book of business. You need to start doing these things. I know over the years, when I was at UnitedHealthcare, we had several agents who had the idea that it's kind of a one and done thing. I sign them up. I don't need to talk to them again. I even knew an agent who had a very large book of business. As soon as AEP was over, he'd discontinue his telephone number. He'd get a new telephone number just so people couldn't reach him. Those days are long gone. You need to keep in contact with your agent relationships. I know, talking with Craig Oberle, Stonehill, he looks at every service contact as an opportunity to cement his relationship. And I think that's how we need to look at it. Next slide, Doug. These are the questions for the CE credit. You'll be getting an email from Terry, and you will need to respond. These are the questions, but before I go through the questions, I want to acknowledge the team at Stonehill putting this together. This wasn't a one-person thing. Nancy was fantastic in putting together some graphics that we used behind the slides in the background. You saw some amazing images. Nancy put those together. We thank her for doing that. I thank Doug for helping me with this presentation, and I appreciate all the information we've been able to get. So let's go through these questions for CE credit. Number one.
Bob, before you start, this is Terry. I was looking at all of these people who have joined the meeting, but I still need to know who is on the phone ending with 0088. And if you don't tell me, you're not going to get the questions. So, because I don't know who it's supposed to go to.
Okay, great. Well, I want to thank Terry too. Terry is part of our team who does a great job in helping us coordinate this with David Oberle, who puts together our invitations. Thanks, Terry. Okay, questions for the CE. Number one, what additional benefits do seniors ask for the most? And that was a big one, and that was a large number. Number two, this is kind of an essay response, and this is your thinking. This wasn't anything we covered, but this is your thinking. And this answers a question maybe we can share down the road that Greg Nelson asked. He asked, what are some of the things we can do to protect our book of business earlier? Anyway, how do I protect my book of business? And again, just maybe a one sentence or a very short paragraph on things that you could share with everyone that we could share in another forum about how can I protect my book of business. Third question. This one's multiple choice. What's the greatest, who has or what product has the greatest Medicare share? We're talking either MAPD, Medicare Advantage prescription drug, MA only, dual SNPs, or supplements. And that's a real easy one. Okay, the next one is another a response from you. What comes to your mind? Some ways to have constant contact with my clients. Again, we'd like to get your ideas so we can share these down the road with other presentations that we make. Again, write those down, jot those down. You'll get these from Terry in a few minutes on your email if she has that. Again, we appreciate all that you all do for your discussion points. I want to thank Doug for his help with this. And again, I don't think we have another one. Would you, in a second here, will you quit presenting, Doug, so I can share something?
Yes, I'll stop right now.
All right. There's something I'd like to show everyone. This has nothing to do with the presentation, but certainly something that I would like to show you that is coming down the pike. We are going to be bringing on a new quoting tool within the next few months that's pretty spectacular. Can you see that, Doug?
No.
Or did I do it wrong? Okay, so I'm going to go back and try to do it over. I'm essentially, if I can't get this up, there it is. Now you should see it. Right?
Yes, it's coming up.
Okay, there's a new quoting tool that we're going to be releasing, and this just shows the Medicare supplement. You can plug in the dynamics, the age of the person, gender, non-smoking, Plan G, and I just put this in so you could see it. What's interesting about this quoting tool is this quoting tool is going to bring up, depending on the zip code you enter, it's going to show every Medicare supplement available. But what I think is really interesting is over here on the left-hand side, well, at the top left corner, if you can see my cursor, it's showing the premium price. But if you go down here, it's going to show how the premium is going to increase over the next 5 years and what the percentage of increase is. It also has a market data over here on the right. And again, this is something, part of a new quoting tool that we're going to be releasing to all our agents very soon, within the next, I think, month and a half. And this quoting tool, it will have the ability, it's not showing it on here, but we'll have the ability that you should be able to send out an application electronically and do things digitally as well. I just wanted to show that to you, that the new quoting tool is really exciting. We're looking at it constantly, and we'll be releasing that soon. So with that, I'm going to stop sharing and just open it up again to tell everyone how much we appreciate you, and we look forward to making sure you get your CE credits accredited. So make sure you get a hold of Terry from that. Anything else you want to end with, Doug?
No, just thank you all for your participation. Thank you for coming, and we'll hopefully see you next time.